Acute infectious diarrhea. Gastrointestinal complaints, including diarrhea, are a frequent cause of visits to healthcare providers. The clinical spectrum of diarrheal illness is broad, as are the etiologic agents, which include bacteria, viruses, and parasites. While infection is a common cause of diarrhea, only a small portion of patients benefit from antibiotic therapy. Like the other clinical syndromes we've discussed throughout this course, the emergence of antibiotic resistance has complicated the management of these patients, especially those who are severely ill for whom antibiotic therapy is indicated. Increasing drug resistance among gram-negative organisms, such as Shigella, Salmonella, and Campylobacter species, have been well documented throughout the world. Antimicrobial misuse has accelerated the emergence of these resistant organisms. Importantly, in communities where antimicrobials are available without a prescription, patients with diarrhea also self-treat, often exposing themselves to drugs that are not indicated or not effective. In this module, we will briefly review non-epidemic diarrhea and the role frontline clinicians play in improving the use of antimicrobials for these common conditions. Let's begin this module with a case. An otherwise healthy, non-pregnant 18-year-old woman presents with a fever, abdominal cramping, and diarrhea for 1 day. She has not vomited and has been taking fluids without difficulty. She had 3 watery bowel movements in the last 24 hours without evidence of blood or mucus. The patient has just returned from a trip to a country with a high prevalence of diarrheal illness, where she herself had no illness. She has not recently taken antibiotics, and her physical examination is normal. There is no evidence of dehydration. In addition to assuring that the patient will be able to maintain adequate intake of fluid and electrolytes, should she be given empiric antimicrobial therapy. Acute diarrhea is generally defined as at least 3 loose stools in 24 hours, lasting for less than 7 days. As previously noted, a number of potential pathogens can cause diarrheal disease. Although broadly categorizing acute diarrhea as either watery or bloody provides clinicians with some focus, the list of potential pathogens for both categories remains long. The most likely pathogens causing diarrhea in an individual patient depend on her exposure and travel history, as well as her clinical presentation and the status of her immune system. While the discussion of diarrheal epidemics is beyond the scope of this course, it's important to remember that epidemics of watery diarrhea are commonly caused by viruses. In some countries, however, the infection with Vibrio cholerae must also be considered. Epidemics of bloody diarrhea are often due to Shiga toxin-producing E. coli or Shigella. Clinicians who observe an increase in the number of cases seen in their practice should alert public health officials to ensure the early detection of an outbreak. Rehydration is the cornerstone of management of acute diarrhea, regardless of the etiologic pathogen and the severity of disease. For most cases of watery diarrhea, watchful waiting without empiric antimicrobial therapy is sufficient. For patients living in resource-rich communities with no travel history, viral gastroenteritis is the most likely cause of their symptoms, and supportive management is the appropriate strategy. For patients with bloody diarrhea, decisions regarding empiric therapy must be individualized. Shiga toxin-producing E. coli infections must be a consideration for any patient with bloody diarrhea. Treating infections due to this organism with antibiotics should be avoided because they may cause harm, namely hemolytic uremic syndrome. U.S. guidelines recommend the use of empiric antimicrobials only in certain circumstances. We will review these recommendations later in the module. Traveler's diarrhea is defined as clinically significant diarrhea that occurs during or within 2 weeks of returning home from travel. Clinically significant diarrhea is generally defined as 3 or more episodes of diarrhea in 24 hours, with at least one other accompanying symptom, including abdominal cramping, nausea, vomiting, or fecal urgency. Individuals who travel to areas with poor sanitation and limited access to clean water are at greatest risk of developing traveler's diarrhea. The most common etiologic agent is enterotoxigenic E. coli, although many other pathogens can cause this syndrome. Most etiologies cause only self-limited diarrhea, with symptoms lasting 1 to 5 days. Some patients may request pre-travel antibiotic prescriptions in the event they develop traveler's diarrhea while abroad. The choice of agent depends on the patient's travel plans. Clinicians should check the enteropathogen susceptibility profiles at the destination locale in order to ensure they prescribe an antimicrobial that is likely to be effective. For example, given increasing Campylobacter resistance to fluoroquinolones in South and Southeast Asia, most recommendations favor macrolides, with azithromycin being the preferred agent. It is important to counsel patients that antibiotics should be reserved for severe disease, that hydration is critically important, and that they should seek medical attention if they develop signs of systemic disease or bloody diarrhea. The use of antimicrobials in this setting must be weighed against the possibilities of toxicity and the emergence of drug resistance. It is also important to counsel patients regarding ways to avoid contracting traveler's diarrhea, including avoiding potentially contaminated food and beverages. There is evidence to suggest that many travelers do not strictly adhere to these precautions, so practitioners should also ensure that travelers receive appropriate pre-travel vaccination based on their health status and destination. Let's return to our case and discuss the principles of empiric antibiotics for patients with acute diarrhea. First, how severe is this patient's condition? Not severe. She has watery diarrhea, but not bloody diarrhea. She has normal vital signs and no signs of systemic illness except for fever. She is not severely dehydrated. She will not require hospitalization. What is the likely cause of this patient's diarrhea? This illness developed shortly after her trip, thus she most likely has traveler's diarrhea. While the traveler's diarrhea is most commonly caused by a bacterial pathogen, in some circumstances, viruses and parasites can be the causative agents. For example, norovirus gastroenteritis outbreaks have been reported on cruise ships. How likely is it that this infection will require antimicrobial therapy? Given the emergence of drug-resistant enteropathogens worldwide, infection with resistant organisms is certainly possible. However, given her mild presentation, empiric antimicrobial therapy is not indicated, as most episodes of traveler's diarrhea are self-limited. And finally, do I need to obtain cultures? Given that most cases of infectious diarrhea are self-limited, stool cultures are not always necessary. They should be obtained from individuals with severe illness, bloody diarrhea, high fever, persistent symptoms, or in patients with comorbidities such as HIV that confer greater risk for unusual pathogens. Stool studies, including routine culture, enzyme immunoassays, latex agglutination tests, and single-target molecular testing may also be warranted in the setting of a large outbreak without an identified etiology. Some laboratories have recently adopted multiplex PCR assays for the evaluation of acute diarrheal disease. These assays combine evaluation of many common viral, bacterial, and parasitic causes of diarrhea into one assay to reduce laboratory turnaround time. However, in this specific case, stool cultures are likely not necessary. You decide against empiric antimicrobials and do not send further laboratory tests. The patient is scheduled for a follow-up appointment 2 days later, and upon her reevaluation, she feels much improved, without fever, and with resolution of her diarrhea. Now let's imagine you are evaluating another case. This patient is a 66-year-old woman who presents to your office with fever and reports a maximum temperature of 38.6 degrees Celsius. She also reports abdominal pain and bloody diarrhea for 3 days. She has vomited, but has been taking fluids without difficulty. She had multiple bloody bowel movements in the last 24 hours, with some mucus, and she also reports tenesmus. The patient had just returned from a lake retreat where she went for a family reunion. She did not go in the lake, but instead spent time in the cabin with her grandchildren and prepared food for grilling. She has not been in contact with other family members, but is not aware of illness in others. She has not recently taken antibiotics. Her physical examination is remarkable for evidence of moderate dehydration and diffuse abdominal tenderness. She declines a hospital admission. In addition to rehydration, should this patient be given empiric antimicrobial therapy? For patients with bloody diarrhea, decisions regarding empiric therapy must be individualized for each patient. Empiric antimicrobials should not be given to all patients with bloody diarrhea due to the harm associated with antimicrobial use in patients infected with Shiga toxin-producing E. coli. However, this is not the only pathogen that causes bloody diarrhea. U.S. guidelines make the following recommendations. For immunocompetent children and adults with bloody diarrhea, empiric antimicrobial therapy is warranted in the following circumstances. Infants who are less than 3 months of age with suspicion of bacterial diarrhea, ill immunocompetent patients with fever and signs and symptoms to suggest an infection due to Shigella, including abdominal pain and bacillary dysentery, frequent scant and bloody stools, fever, abdominal cramps, and tenesmus. Or people who have recently traveled internationally with fever and evidence of sepsis. Guidelines recommend the consideration of antimicrobials for immunocompromised individuals with fever, severe illness, and bloody diarrhea. Let's return to our case. How severe is this patient's condition? In contrast to the young woman from Case 1, this patient has moderate to severe invasive disease, evidenced by fever, dehydration, and bloody mucoid stools. The patient has also recently traveled. It is most likely that she acquired this infection while at the campsite. The possible infectious etiologies of acute bloody diarrhea with fever include enterohemorrhagic E. coli, Shigella, Campylobacter, non-typhoidal Salmonella species, and Entamoeba histolytica. Given the emergence of drug-resistant enteropathogens worldwide, infection with resistant organisms is certainly possible, but most likely reflects local resistance rates, given that this was a locally acquired infection and not the result of international travel. And finally, in this case, you should obtain stool and blood cultures given the severity of her presentation. You decide that empiric antimicrobial therapy is warranted. She is immunocompetent, but has fever, abdominal pain, frequent bloody stools, and tenesmus, and you consider shigellosis as her diagnosis. You reference your local guidelines and decide to prescribe ciprofloxacin as she is able to tolerate oral medications. You reevaluate her over the next 2 days while she convalesces at home, and she is now afebrile with normal vital signs and only 1 to 2 loose stools a day. Her blood cultures did not grow a pathogen, however, stool culture grew Shigella flexneri. You reference current literature and local guidelines from your health ministry or health department and feel confident in your choice of a 3-day course of ciprofloxacin. Briefly, Shigella species are among the most communicable pathogens, requiring only a very small inoculum to cause infection. Shigellosis is self-limited and does not always require antimicrobials for cure of diarrheal symptoms. But asymptomatic fecal shedding of the bacteria may occur after acute infection and pose a risk of family and community transmission. As a consequence, many favor antimicrobial therapy in response to a positive stool culture for Shigella, since such therapy shortens the duration of symptoms and reduces the risk of human-to-human spread. Reduction of new cases may also contribute to less community antimicrobial exposure. Let's return to Case 2 and imagine an alternative ending. Let's imagine that her clinical condition has worsened instead of gotten better, and you are evaluating her in the hospital rather than in your office. She is persistently febrile, complains of severe abdominal pain, vomiting, and non-bloody diarrhea of at least 10 episodes in the last 24 hours. She is hypotensive, but that blood pressure responds to 2 liters of normal saline. She remains on maintenance intravenous fluids, and she is unable to tolerate an oral diet. She has been admitted for dehydration and evaluation of possible etiologies. Because of the severity of her presentation, you order stool and blood cultures. Upon further interview, the patient reports that several members of her family have been ill recently with similar gastrointestinal complaints. All the sick family members live in close proximity to one another and work on the family farm raising cattle, poultry, and swine. The severity of illness among the family members varies, and most are convalescing at home, although one other family member, a 9-month-old girl, is also admitted to a local pediatric hospital. How severe is this patient's condition? This patient has severe disease, evidenced by the number of diarrheal episodes per day and her abnormal vital signs, including hypotension and persistent fever. This patient lives in close proximity to many family members and to animals. It is likely that she acquired this infection from her home environment. The possible etiologies of acute diarrhea with fever include Shigella, Campylobacter jejuni, non-typhoidal Salmonella species. This patient's illness progressed despite taking fluoroquinolones, thus you suspect that her infection is due to a resistant organism. In this case, you should obtain stool and blood for culture given the severity of her presentation. You decide that empiric antimicrobial therapy is warranted, and you decide to prescribe ceftriaxone due to her inability to tolerate oral antibiotics. Your patient stabilizes over the next 4 days, and she is now afebrile, with normal vital signs and only 1 to 2 loose stools a day, and is again able to tolerate an enteral diet. Her blood cultures initially grew gram-negative rods at 48 hours. The pathogen was subsequently identified as Salmonella enteritidis, and her stool culture confirmed the same organism. Subsequent blood cultures drawn for persistent fever at 36 hours into her hospitalization remained negative. Susceptibility data demonstrates that this organism is resistant to nalidixic acid and fluoroquinolones. You reference current literature and local guidelines from your health ministry that supports a 14-day course of cephalosporins for this disorder. In brief, Salmonella are gram-negative facultative anaerobic members of Enterobacteriaceae and are a common cause of human infections, particularly gastroenteritis caused by non-typhoidal Salmonella and enteric fever, which is caused by Salmonella typhi and Salmonella paratyphi. Laboratories often use a combination of biochemical markers and serotyping to identify causative organisms. Extremes of age are a significant risk factor for invasive infection, often requiring hospitalization, as was the case for this patient, who is greater than 65 years of age, and her infant relative. Salmonella is often implicated as a cause of foodborne outbreaks, but can also be acquired from close proximity to animals or from person-to-person transmission from known carriers to susceptible hosts. Antimicrobial resistance in Salmonella varies markedly depending on geographic region, and local resistance data should inform empiric regimens, particularly with regard to empiric fluoroquinolone versus cephalosporin administration. In this module, we reviewed important principles to promote the optimization of antimicrobial use in the management of acute diarrhea. These principles include that not all diarrheal illnesses require or respond to antimicrobial therapy. For most patients with mild watery diarrhea, antimicrobial therapy is not indicated. In contrast, patients with evidence of invasive disease or systemic spread should prompt the consideration of empiric antimicrobials. Clinicians play an important role in educating their patients about the self-limited nature of mild watery diarrhea and should counsel them to avoid self-treating with antimicrobials obtained without a prescription. Avoiding the prescription of unnecessary antibiotics can save a patient from both unnecessary exposure to antimicrobial effects and avoids the risk for other adverse events from medications, including allergic reaction, renal dysfunction, and hepatic toxicity. It can also have a societal benefit of reducing selective pressure driving antimicrobial resistance.